We'd like to begin. There is more food back there if any of you want to keep eating, but we want to be respectful of about 24 different time zones sitting in this room right now, and many of you are on different ones and have been traveling long to get here. So we want to talk a little bit. This is a very unique occasion, the first time in my memory of any meeting quite like this, where literally many of you from institutions around the world had a chance to come together. I'm very clear in my mind the most important part of this whole meeting is happening over the last half hour, as you all have connected, and over the next few days as you connect and be able to talk and get acquainted and can listen to each other, learn from each other, and so on. That social capital, that social connectedness is an incredibly important part, particularly when people are scattered out in different places and often don't get a chance to meet with others very frequently. It's a personal pleasure for me to know many of you from the field and then finally have you come and visit our place. This is Loma Linda, and for many of you, you haven't been here before, so it's a privilege to have you here. Some of you asked me to do this and that, and I will try to do that, though I heard a saying the other day, being president of a university is like presiding over a cemetery. There's a lot of people under you, but no one is listening. So we'll try to do what we can, but this is Loma Linda, and I can see my officers and deans over here aren't laughing because they kind of know how that is. So. We will have a chance to introduce some people later on as we talk, but I wanted to start off by thanking several groups. And first, our Global Health Institute on campus. It started, 3 years ago now, 2 or 3 years ago now, are really the ones that have put together this whole conference. And guys, walk up here a bit closer so we can see you. Jan's over here, well, a bunch of the people here, all of you, all the GHI folk, please stand. Jan Daly, Amanda Biddle, Cheryl Lake, Jerry Daly you met, Mighty Mo, please stick your hand up, Mo. This is the one that got you all here. So. Can't see you all. Bing is back there that helped arrange all this here. So thank you to all the GHI people for putting this together. There's no small feat. I can tell you we were, who was telling me, somebody, they got their visa at 4 o'clock Monday afternoon and 4 hours later got on an airplane. So some of it was that close. Unfortunately, there's quite a few people that aren't here that we couldn't get visas for. It's not easy to do that. We have a group from Nigeria that couldn't get visas, several different countries that people couldn't get visas to get out of the country because the U.S. State Department gets pretty picky on these things now, and so it doesn't always work the way we'd like it to work. But we are streaming it live, and hopefully you all will have a chance to send information back to different ones and let them know if they can pick up some of the programs that's here. I'd already introduced Lowell Cooper, who's chairman of our Loma Linda boards and our AHI board, and we appreciate him being here. I also want to introduce Pardon Wansa. Pardon, are you still out there? Pardon Wansa is another General Conference Vice President on our AHI board. He's sitting with the Zambia table as if he's still Zambian, but we know better. But it's good to have you here, Pardon. Several other groups I want to thank, and as you know, over the last 2 or 3 years, we have been increasingly sending containers of equipment and supplies and so on out. We gather those in various ways, but the Quiet Hour has been our partner in covering the shipping costs of the containers, and that's been invaluable. So where did they go? Here, Bill Tucker and Randy Bates, head of the Quiet Hour. Don't blame them if you don't get what you want. That happens at a different level, but we're delighted with what they have partnered with us on and helping to get containers of things around the world. We tried for a long time to stay out of shipping equipment and containers because it's expensive and difficult, but it probably is the single biggest need we have in many places, and so we have gotten back into it and have relationships where we can obtain equipment. It isn't free. It takes a lot of work. Jerry Daly is the one that spends a lot of hours down there packing these containers and filling them up and sending them out. We also have some folk from some of our other hospital systems, and I see both Steve King and Greg Hodson here. Are there others here that I don't know? And Monty Jacobs, I should know that. Please stand. Steve and Greg are from Centura System in Florida, and Monty Jacobs, excuse me, in Colorado, and Monty Jacobs from Florida. I think it's true that increasingly our hospital systems in this country, which is about 80 hospitals now, are partnering with institutions around the world and becoming involved in various ways. And I very much appreciate that, many of them sending out the clinical teams at different times to make things happen. I also want to introduce, and maybe, Christy, why don't you introduce and tell a little bit about America. Christy Shank is a medical director from Malamulo and has a special guest with her.
I'm pleased to introduce Dr. Adam Zayan. Originally from Egypt, we know him through AmeriCares, a partner NGO that we work with based out of Connecticut. Dr. Zayan is the vice president for
Global Partnership.
Global Partnership, thank you. Where I have actually just met him today. We've worked with many of his team members. AmeriCares and Malamulo have partnered for about 10 years now, and we receive about 6 to 8 containers every year, and so we're delighted to have him here as well.
Well, thank you for inviting me.
We probably need to provide him a bodyguard now so that... I am sure there's others I should be mentioning, and I will hear about that as soon as we're all done. But let me start talking a bit. I want to kind of share some comments and perceptions. Unlike what I normally do, I'm actually going to look at some notes occasionally. The Adventist Church has been known for healthcare since its beginning, and has had an illustrious history, I think, in that. If you think about health, though, within the church, there's actually 2 components to health. And we're only talking really about one over this weekend. One of them is personal health. And the health messages we talk about and all the things that we do in personal health is something that we all seek to follow, something the church certainly promotes, and something that's a key part of who we are. But at the turn of the last century, in the late 1900s, it was clear from Ellen White and others that health care, providing health care to others, is also an important part of this church. And so the whole health care system got launched. Malamulo was not actually the first. Loma Linda was not the first. Malamulo beat us, Christy, by about 2 or 3 years. But even before that, of course, was Battle Creek Sanitarium. And Battle Creek Sanitarium, started by John Harvey Kellogg, really established the health work of the Adventist Church as a key part of who we are and positioning us around the world. In 1895, John Harvey Kellogg started the American Medical Missionary College, AMMC, as the first medical school operated by the Adventist Church in Battle Creek, Michigan. That medical school lasted for just 15 years and was shut down. But the teachers, the graduates from that school actually are the ones that started Loma Linda. And if I could have the first slide on, I want to show you a couple of pictures from the old days. We may need to dim the lights a bit to pick up these slides. This is our first nursing class, Marilyn, from Loma Linda. 7 students. You will note that it had 5 women and 2 men in the first nursing class of 1907 from Loma Linda. They happened to be holding the baby of the president of Loma Linda at that time. And out of that class went the first missionary from Loma Linda. Almeida Kerr went down to Uruguay and started the medical missionary work of the Adventist Church in 1907, right after graduation. The medical school started shortly thereafter, and this is a picture of the first graduating class from AMMC, American Medical Missionary College in Battle Creek. And among those is Dr. Alfred Shryock, for whom then later joined our faculty and for whom Shryock Hall is named. And for some of you who haven't walked our campus yet, and we'll show you a slide in a minute, that rock was their gift to the American Medical Missionary College upon graduation in 1899. That rock now sits in our Founders Plaza up here as part of the beginning of Loma Linda, because really from AMMC came a number of the faculty that helped to start Loma Linda University. And to prove to you that we did community health work even back then, this is our students going on some of their community service activities. Our students don't dress as well anymore, I can tell you. But you can see this is Loma Linda Sanitarium heading out to community service in San Bernardino back at the beginning of this institution. And really out of that has come an incredible period of time. And if you add up the hospitals that were started from 1900, when our graduates first started going out, to 1950, the Adventist Church started approximately 2 hospitals every year for 50 years. That's pretty incredible. Certainly not all of them by Loma Linda graduates, but many of them by Loma Linda graduates. That was their passion. That was the reason this institution was started. They started going out all over the world. The first medical school group, and I don't know them all well enough, but went to out of this first class, went to India, went to the Philippines, went to China, and after that started scattering all over the world. And as a result of that, we have ended up with a fairly incredible hospital system around the world. Many of you know it because you're part of it, and have been part of it all these years. We've got 11 hospitals in India. What many of us don't realize, we had 23 hospitals in China before the Great March, when Mao Zedong came through and took them all over. The Adventist Church then went on for the next 50 years without any institutions in China. Sir Ranwan Shah, that we've been involved with now, is not our hospital, it's a government hospital. But I'm pleased to say that we actually started about 2 weeks ago a working group here on the campus to consider planning an Adventist hospital back in China once again. It looks like the politics are good enough and the reputation is good enough that there's a chance of actually starting a nursing school and perhaps a hospital in China someplace. And so we have a working group starting to look at what it will take to do that. And of course, Africa, we have 25 hospitals scattered across Africa. We got 20 plus scattered across various parts of Asia, and over 20 in both in America and South America. Those were the golden years, and I think it's fair to call them that. If you go back and look at the U.S. State Department records, they will frequently say for their diplomats, if you get ill in this country, the place to go is find the Adventist hospital. And we went through many years in which we represented the cream of the crop in many of these countries, hospitals that were literally recognized as the best possible institution to go to. But then we started a long transition, and a transition that has led us to where we are at today, basically in the 60s and 70s. Back in the early 70s when I was working in Tanzania, it was certainly happening, in which many developing countries of the world started moving towards independence. And that was appropriate. There was a push by many governments to take over private hospitals. The Adventist Church resisted that considerably. Some other churches said, fine, we've done our thing, you can have our hospital. But the Adventist Church has always viewed hospitals as being more than just a humanitarian effort, and so we tried to hang on to our hospitals. We lost a few, but not too many of them. But we went through a transition in which during that time, a number of different things started happening. The donor base in America started gradually going down. The amount that our people in North America were giving to mission offerings to support our institutions started going down gradually about that time and just kept on going down. The General Conference policy for a number of years was that when a missionary was to go, particularly a Loma Linda graduate, half of their debt would be amortized by the General Conference. The other half would be amortized by the calling institution. Well, that worked fairly well when hospitals were strong and able to survive and pay debt. But when Loma Linda debt kept going up and hospitals kept getting weaker, those lines crossed about 25 years ago, and the policy no longer allowed Loma Linda graduates to serve at most hospitals around the world. And for probably the last 15 to 20 years, the only institution that could call a Loma Linda graduate was Guam. None of our other hospitals were strong enough financially to pick up a debt. A Loma Linda debt now is around $150,000 to $200,000 by the time a physician or a dentist graduates from Loma Linda. And to ask a mission hospital to pick up half of that debt simply wasn't possible. And so as a result of that, there was fewer and fewer Loma Linda graduates going to work around the world. And when I stopped and added this up about 10 years ago, 12 years ago, there were 3 Loma Linda graduates as physicians. There's a couple dentists and 3 physicians in all of Africa, as an example. As compared back in the 1970s, when I worked out there, there was probably 20 or 25 Loma Linda graduates scattered around in different institutions. This caused the church to go into a tough time of discussion. And I need to tell you, there was real serious questions whether that it had come to the point where mission hospitals were no longer possible for us to maintain. They were increasingly complex, they were expensive, and the return in terms of evangelism, in terms of baptisms, frankly, wasn't what you could get out of a school or out of some other means. And so the church leadership honestly started reevaluating, is it possible, should we be trying to maintain this many mission hospitals scattered around the world? And that was a tough time for the church to try to answer that question because they cost money, they are complex. And as we transition to more and more national leadership in the union level, and church policy typically has union presidents serving as chairman of hospital boards, the whole question of whether we had launched an enterprise that was not possible to maintain was seriously and entered into by the church leadership. It was in 1997 that here at Loma Linda, and I'll never forget the meeting, sitting in our conference room up in McGann Hall at a board time, Dr. Behrens, who was president at that time, had written Loma Linda's strategic plan. And that strategic plan, as only Dr. Behrens could do, was fairly long and fairly verbose, but very detailed, and many, many things that we were supposed to do. And as we were sitting, the deans were sitting around the table and reviewing the strategic plan, and we were all nodding, yes, we all plan to do that. Yes, that's who we are, that's what we're doing. One of the board members said, here's a line that says, and Loma Linda University will help strengthen Adventist mission hospitals around the world. And the board member says, looked to all of us, says, are you serious? And if so, how are you going to do that? And that started a discussion on our board at that time that says, are we serious about trying to strengthen this? Because many of us recognize that our hospitals were on a trajectory that was basically end up with quite a few of them closing if we didn't significantly change something. That board committee asked for a discussion group to start on campus. A number of us started getting together over the next year or two and started talking about, is it possible to change the trajectory and literally bring mission hospitals back to life again? And I don't want to overstate this because some of these hospitals have always thrived and some will do well whether or not Loma Linda was here or not. But it was very clear that in a number of the areas of the world, these hospitals would not make without repositioning somehow how we did this. And let me just give you a couple of stories of what came out of some of our travels at that point in time. And if I can walk you, and I'm going to have a hospital in mind that I want to identify, but it could be any one of a number of hospitals. Where you walk in the front door, the screen door hangs at a little bit of an angle because they hadn't repaired it for some time. The screen is ripped. The paint on the side of the building is peeling. You walk inside, the halls are not real clean. You ask to see the laboratory, and they open up a small room. There's one rusty microscope that hadn't been used for some time. You ask to see the x-ray. The x-ray machine had been broken several years before and hadn't been fixed. The patient beds could hardly crank and move anymore. The sheets are old, and the staff is discouraged. They hadn't been paid for 3 months. We moved to the kitchen. The kitchen staff were producing good food. There were 7 of them in this particular hospital preparing food for 3 patients. That's the hospital occupancy. Because, see, we got caught in a time when working at a hospital, church employment was considered an entitlement. Once you got a job, you expected to have a job for the rest of your life. And when hospital occupancy went down, when times got tough, No one was let go. And while we can all argue for that on its humanitarian basis, that's important to support our people, it simply led hospitals into bankruptcy. And we went through years in which hospitals were getting further and further and further in debt and propped up by various means, but simply weren't able to meet the expenses that they had. It was about that time that AHI, Adventist Health International, started being discussed. Was it possible to recreate a model that would somehow help these hospitals to get back on their feet again? And what was clear is we needed a new system of governance, of running hospital boards. We needed a new system of management. The management needed to be held accountable and responsible. We needed a new system of donors, because donors had kind of given up on our hospitals, partly because they were discouraged, partly because they were not hearing any more stories, because the people from the States, where much of the money came from, were no longer working out there. They were no longer coming home and telling stories. And so the awareness of the needs in the mission field had been going down. At the same time, there was a national team coming up at a number of institutions that were important and vital. But unfortunately, as we talked today in some meetings, many of those who looked at the Adventist employment system in the hospitals says, sorry, I've got better opportunities elsewhere, and basically chose not to work for the church because of either salary levels. We can blame that if we wish, but many times it was just the whole morale, the whole sense of this institution is not a place that was going to succeed. And so we went through several generations of our young professionals coming up in training in different countries who basically got discouraged and chose not to remain in employment of the church. If you look at Africa today, it's estimated, for instance, in Africa, that 90% of the physicians educated in Africa are no longer in Africa. 90%. Because there's other opportunities, they have skills that are valuable, and many of them, quite understandably, say, I want to do the best for my family, let me move on. And that's not just true in Africa. I mean, in many parts of the world, that happens. So the question was, how do we create a model, an excitement about once again working abroad? And I want to suggest several options. Because in the United States, actually, we went through a somewhat similar thing. If you look at where we were at in about 1980, we had about 50 Adventist hospitals in this country. They were all under union leadership, chaired by the union president, a board chaired by the union president, and operated as part of the church. Between 1980 and 1982, the U.S. started forming health systems because we recognized that the complexity of hospitals would require a new system of governance and management if it was going to meet standards. And so during a 2-year period of time, systems were formed across this country, and those hospitals all gradually moved into health systems that then could bring in professional management, professional expertise to try to upgrade those institutions and keep them up to date. And since that time, the Adventist health systems in the U.S., and there's 5 systems and a few other scattered hospitals now in this country, have done very well. They've grown. We now have 87 hospitals in this country and have become, I think, some of the best hospitals in the country. If you look at Adventist Health System in the south and middle of the country, Adventist Health out here in the west, Adventist Healthcare, Inc. In the east, Kettering Medical Network around Kettering, we've got some very valuable hospitals that have done very well. The question the church has struggled with is, have we lost something by having hospitals be professionally managed? Is there something that you lose by not having them directly under the church? And it's a legitimate question. It's one that I think needs to be asked and has been asked many times. And I hear many of your church leaders around the world struggling with that, saying, whatever we do, let's don't move out from under that sort of model. I would like to suggest that I believe it is possible to have both professional management as well as church connectedness. there is no reason why we cannot have the best hospitals in the world once again, why we cannot recapture our reputation in some of these countries and have quality hospitals and still be very much identified with the church. But it's going to take us all moving into a different sort of system of management, a different level of understanding of what it takes to run quality hospitals. Let me come back and talk a little bit about Loma Linda and what we are trying to do as part of this. And over the next day and a half, we'll also be able to listen to some of the other systems because this needs to be a team effort. We have a program here called the DMA program, Deferred Mission Appointee Program, that basically is for any medical student or dental student at Loma Linda that's already a student at Loma Linda. We don't give them a loan. We don't pay them to go to school or pay their tuition. We let them go to school. They pay their own debts. But when they graduate, we will cover their debt payments while they go to serve. And that program has been very effective. And as the hospitals have started coming back online around the world, our students see that. We now have 60 medical students in the DMA program at some point in their training, either in medical school or in residency, waiting to go serve abroad. We also have probably, I think it's about 10 dental students in that program. But a few years ago, what we recognized is that while doctors are important and dentists are important, they're not the only ones that are important. And many other disciplines are frankly just as important in trying to make a hospital run. In fact, if I could make a plea for the nursing profession, having watched a number of hospitals struggle, nursing care, quality nursing, is more important than quality doctors in making a hospital work. And we have got to fix that. We have got to get that part of the system going as well. And I can talk about all the other disciplines increasingly, all the allied health disciplines, physical therapy, occupational therapy, respiratory therapy, radiation technology, laboratory technology, all these things, medical records, are all critically important areas to make a hospital the level you want. So several years ago, we put together another fund we called the Global Service Award Fund. And several of our schools, Maryland's here from nursing, helped to start this, put money into that. That now is built up to about $500,000 so that now we can actually pay the educational debt of any graduate of Loma Linda, of any discipline, for them to go work abroad. That has suddenly opened up the whole world for this process. We also, in 2005, were able to change the DMA policy, which was a critical change, in which our School of Medicine, and I'm forever indebted to them, agreed that every medical student who graduates from Loma Linda who wants to serve abroad, the General Conference will pay half of their debt. The School of Medicine at Loma Linda will pay the other half of their debt. So instead of loading that on the calling institution, now the whole world is once again open to Loma Linda graduates to go and serve wherever the need may be. That has changed the dynamics considerably. From the low of 3 Loma Linda graduates in medicine abroad in Africa, for instance, about 10 years ago, we're now up to 12 and climbing every year as more and more of our graduates go out to serve in these institutions. Some parts of the world are not as easy, and I have some good colleagues here from India. India has been tough. That has been a place where we've I think 11 Adventist hospitals now scattered across India have done very well. Some of those are struggling. Some of those are doing well. The city hospitals tend to do well. The rural hospitals tend to struggle more. Unfortunately, India did exactly what the U.S. has done. The American Medical Association wants to keep its borders controlled for international graduates coming in here, make it difficult for people to come in from other countries. Other countries are gradually doing that as well, and India has done that to some degree also. So it's difficult to continue to send people into India and to be able to function those hospitals, although we have a couple. Chad and Amy, are you here? There they are. Let me embarrass you. I can do that because they're relatives. Chad and Amy Versier are both physicians, and both on our, Chad's on our faculty, and Amy works locally, but they are going out to India, to Ottapalam, here in another month, if we can get everything sorted out, to try to develop a new model in India as well, of trying to help upgrade an institution and once again open up the door for people to work abroad in India. And I'm very pleased with that, and we'll watch how that works out there. and see if we can to try to create the level of skills that we need in these institutions. South America, of course, has been largely self-sufficient for a number of years. And so when I went to medical school, I dreamed of going to South America. That was the place I intended to end up, because that's the stories I was hearing. By the time I graduated, South America didn't need me. And it's largely self-sufficient. Much of Asia is somewhat self-sufficient now, although it's not totally self-sufficient. And the challenge is how to get in there because of licensure issues and so on. It's many times difficult to make things happen out there. So it's a mixed bag around the world. But I certainly personally believe the time has come when together we can do this. And I often talk about us being an extended family or a corporate model. IBM or General Motors wouldn't have a world-class institution in one place and a struggling institution in another place. They would work together. We'd figure out ways to collaborate to make these institutions come together. And I think it's important that we do that. I want to walk you through another set of criteria that we have been using and looking at for some time that we refer to as the institutional benchmarks. And they're an example of where many of you have started with your institutions and where we want to grow out of. So if you look at this, we talk about staffing levels. It's not always true, but it's usually the problem with a struggling hospital isn't that you don't have enough staff. It's usually that you have too many staff. And you don't have a way to reduce the staff to try to make yourself financially viable. There's difficulty recruiting both expatriate and national professionals. Many people don't want to come and work for a struggling institution. The salary is below benchmarks and often tied to the local church system. And employee benefits are often absent. And it's not a good place to work. Employee morale is low. Many times you'll see that payroll is 2 or 3 or 4 months behind in getting paid to people. Cash management is a challenge. External support is necessary for survival, and often the local church or other entities are having to prop up these institutions. Debt management has been a problem. The physical plant has deferred maintenance. Basic equipment isn't functioning. Reputation locally is not good. And if there's any educational programs, often don't meet standards. Many of our institutions have been at that level, and some still are. But it doesn't have to be that way. And the next step, and I won't read through all these, but gradually as an institution starts turning around, and in our experience it takes about 5 years to get an institution back on its feet again. And many of you have watched this in your places to gradually come back. And you can see some of the various things that people go down through. Morale starts picking up. Salary starts getting back on track. You're able to meet local payroll costs from the patient revenue. Debts start being to be paid on time. You start fixing up the building, start getting basic clinical laboratory and imaging equipment in place. And the institution starts to come back. And then you finally get to the stable state. And it's fun to watch this happen. Reserve funds start being put in place. Debts are cleared out. Various things start happening when an institution gets back to that level. And then finally, you get to what we truly call successful, where there's reserves built up, an institution starts coming to life, can literally start planning for the future and what it wants to do. That requires a mature board. That requires skilled management. That requires a quality staff to make that happen. And that is hard work. But my personal belief is we can do this again, and we need to get back to the point where we are trying to do that in all of our institutions around the world. I want to close by raising some questions. So what we have now, we have actually 193 hospitals owned and operated by the Adventist Church around the world. 87 of those are in this country. The rest of them are scattered around the world, a few in the Western world, developed world, the rest of them in what we often would call the majority world. So we have a lot of institutions. We have almost 400 clinics of various kinds associated with those institutions. That's a big enterprise for a church this size to try and maintain. A big enterprise. And yet I firmly believe, and I've watched this enough now to know that every hospital has the potential for being both self-sufficient, at least for operating costs, and can certainly provide quality care where they are. So as we try to move that way, and our goal over the next couple of days in this conference is to try to do that. But some of the questions I want to raise are, number one, who owns an Adventist hospital? Is it the founders? They're long gone. Is it the current staff? Is it the church? And that's a key issue. I mean, who actually feels responsible and feels ownership of these institutions? Now, you'll hear different responses if you talk to the unions, and we have a number of union presidents here, and I very much appreciate you coming. The deed usually sits in the name of the union, although not always. We're struggling with that in some places. Trinidad being an example, as I look at my colleagues here. We've got some deeds actually sit in the General Conference. We're trying to get all ownership to sit locally. But is the hospital the churches? Is it the staffs? And it's an issue, I think, that's critically important, because I'd like to argue that indeed these institutions are owned by all of us. These are not something to be used for any personal gain, certainly. These are indeed something that collectively represent all of us. And when you put your name up on the wall that says Adventist Hospital, you are reflecting all of us. Our reputation goes up and down together. So I think it's critically important that we feel a collective ownership, a collective buy-in to making these institutions have the quality that we want. Healthcare is changing very rapidly around the world. It's becoming increasingly complex. The world of litigation, of lawsuits that we didn't even hear of before in many countries is now becoming a very active part of this all over the world. If we're going to successfully compete, we're going to have that collective ownership be very real. We're going to have to depend upon the assets and resources of many different entities to try to make this happen. I'd like to suggest that it can happen and should happen around the world. Another key part of this is, where do we get the staff? And I think one of the points of good news, I feel, is that increasingly our academic institutions are recognizing that health professional training is a growth market. And many of our institutions are now starting health programs of various kinds. For years we had one medical school here at Loma Linda. And then we added Montemorelos. And then we added River Plate. And now in the last 2 years we've added 3 more at Babcock, getting ready to start one in Peru, getting ready to start one at AUP, Adventist University of the Philippines, in the Philippines. And there's 2 or 3 other countries talking about them. So the medical schools are happening. The dental schools are starting to happening. We have 40 nursing schools. Pat, roughly how many? Nearly 80 now, okay. I don't keep up on nursing as much as I should. So we have nursing schools starting around the world, and many other disciplines starting as well. So we're starting to produce personnel. That's the good news. The challenge is, many of those are being trained in clinical institutions that don't meet the standards that we want to set. And you cannot do good health professional training in the classroom. It requires quality clinical institutions. And that's where many of you come in. We have got to somehow get our hospitals and our clinics to the level where they can provide good training for our students as they come out. And we have to make them attractive employment institutions, or we will train a lot of people and not take advantage of them. So our academic institutions are starting to do their part, and we're delighted with that, and Loma Linda is committed to working with them to help with that. But we've also got to get the clinical institutions up to be able to fully take advantage of where that is going. I want to wrap up by talking just a little bit about Loma Linda. We've got your schedule packed so full that not all of you will have a chance to even see Loma Linda when you're here. I apologize for that. But let me show you by picture at least a little bit what we have and introduce a few more people. Loma Linda currently consists of 6 hospitals and 8 schools. So when we talk about our 6 hospitals, this is the main what we call the University Hospital, the main hospital that you all identify with Loma Linda. This also includes on the south side of it the Children's Hospital, which is one of the busiest children's hospitals in the country. We have an 82-bed NICU, NICU, that usually has over 100 babies in it, and is a very busy part of our campus. If you head on down the road towards Redlands, you'll come across what we call the East Campus. The East Campus is our rehabilitation campus, where such disciplines as orthopedics, neurosurgery, physical medicine, rehabilitation all take place. This is the Zapara Pavilion at the East Campus. And I'm particularly glad to have Nicholas here from La Lignière in Switzerland. This is another campus somewhat similar to what we have here in Loma Linda. If you go down a little bit further down the road, you come to what we call the Hart Surgical Hospital. This is a small but very high-tech hospital where we do all of our robotic surgery and many of our high-tech surgeries at the Hart Surgical Hospital. If you go another little bit down the road, you'll come across our Behavioral Medicine Center. So this is the psychiatric hospital or behavioral health hospital that has 89 beds and one of the best chemical dependency and psychiatric hospitals around. We recently built the Behavioral Health Institute next to it, an outpatient facility that makes this up as well. And then away from this campus, if you head down towards San Diego, you'll find our newest hospital, Loma Linda University Medical Center, Murrieta. This is a new 106-bed hospital that we just opened a little over a year ago down on the other side of Riverside, and we're pleased that it's really picking up steam now and doing quite well. So those are the clinical facilities that make up Loma Linda. There are 8 professional schools at Loma Linda. The School of Allied Health Professions, and I'm going to start introducing people here now. Who's here? Where's Ernie? Way in the back. Craig Jackson, who is our Dean of the School of Allied Health Professions, was back east, isn't home yet. Ernie Schwab is the Academic Dean in charge of the School of Allied Health Professions. This has all, I don't know how many disciplines you have, Ernie. What do you consider yourself to have? 9 different disciplines. So this is PT, OT, med tech. I'm going to get in trouble here pretty soon. I see some of you already looking daggers at me, Laura. What I forget to mention. This is our largest school on campus. This has well over 1,000 students in this school. So the largest school by number of students is in the Allied School of Allied Health Disciplines. It's up on the hill primarily, although they're scattering many places now, but in the old hospital on Nickel Hall up on the hill. So that's our School of Allied Health Professions. Next is a school that we've recently renamed the School of Behavioral Health. This used to be the School of Science and Technology. We now call it the School of Behavioral Health. This has social work, marriage and family counseling, and psychology that make up this school. I know Bev Buckles is out of town, but who is here from, anybody here? Curtis Fox, a transplant from Trinidad. Stand up, Curtis. But is chairman of the Department of Counseling and Family Sciences, representing the School of Behavioral Health. Our School of Dentistry, quality school. You'll walk by it out here, and Charlie Goodacre Dean out of town, but Ron is here. Please stand up and let us recognize you. The School of Dentistry, a lot of innovative research and various other things that happen in the School of Dentistry. The School of Medicine, our second oldest school. I say that for Maryland's benefit, but Loma Linda is often identified with the School of Medicine, and we're certainly proud of our School of Medicine, but it's only one of 8 schools here. There's much more besides Loma Linda than just a School of Medicine. They've just celebrated the centennial starting in 2009. For the next couple years until 2014 was their first graduating class. What many of you don't realize is School of Medicine has also a number of PhD programs in the basic sciences and various things, and trained faculty for different places. We have 700 residents, physicians and specialty training of all different kinds both at our hospital and our affiliated hospital. So there's a lot of specialty training taking place as well through the School of Medicine. Our oldest school, the School of Nursing. Marilyn Herman is here, our dean. Please stand, Marilyn. And the School of Nursing is one that's been very active in running off-campus programs. They're just finishing their second off-campus program in Thailand. in Thailand, and also had one that started off in Argentina but ended up in South Africa that finished a bit. And those of you from Africa, please lean on her, because we think we ought to start the next Africa program back in Africa again. I don't quite have Marilyn convinced, but I'm working on her. But that's been an incredibly valuable, what? I didn't have Henry stand. My goodness, I'm going to back up. Well, have both of you stand. Henry Lamberton and Roger Hadley's out of the country, our Dean of Medicine, but please, Henry Lamberton, Associate Dean for Student Services, and Tammy Thomas, our Vice Dean from the School of Medicine, is here as well. Thank you. My wife keeps me out of trouble here. And the School of Nursing, and we have a Doctor of Nursing Practice program that started recently. This is nurse practitioners up at the doctoral level that we're pleased to have in that program. One of our newer schools, the School of Pharmacy, has been going for, 8 years now? I saw Billy here earlier. Is he still here? Had to leave. Okay, Billy Hughes is Dean of our School of Pharmacy. They have just moved into their new quarters here in Shryock Hall across the road from us. That's a doctoral level program in pharmacy. School of Public Health, Tricia Pennycook, that has come to us from Inter-America, but we're glad to have her here. And our dean in the School of Public Health. They're getting ready this coming spring to have the 5th International Congress on Vegetarian Nutrition that some of you may want to come back and be part of. And our School of Religion. John Pauline is here. Please stand, John, as Dean of our School of Religion on the campus. I wanted to comment just briefly about SAC Health System. This is a large clinic we have in San Bernardino that was given to us by the Air Force about 17 years ago now. I consider this the first step towards people preparing to work abroad, because this is where we see about 30,000 patients a year, many times people without insurance, many times people in other cultural backgrounds, and so it's an excellent place for our students to gain exposure to working across cultural and economic boundaries. And there's a lot of other things that happen in the community that we won't take time to go into. One final introduction one group I need to do first, and that's the officers of the university that are here tonight, and some of them are not. But let me start. I want you all to get acquainted with them. Rod Neal, our Senior Vice President for Financial Affairs for the university. Judah Storfgel will call part of the university. She has just joined us from our board, but Judy is a nurse and is the Chief Nursing Officer for the Medical Center, as well as in the School of Nursing. Carrie Dominguez, our Senior Vice President for Human Resources, that is here. And now I'm going to start looking. Who else is here? Kevin Lang is here. Kevin, please stand. Kevin also serves as chair of our board, HI Belize board, but is our CFO for the parent enterprise, the Luask enterprise here, and we're glad to have him here with us. And I had 2 more just walk in the back, so thank you. You guys timed it well. Rochelle Bassell is the attractive one. Rochelle is our Vice President for Advancement, which includes public affairs, development, and philanthropy. And Dr. Ron Carter, that is next to her, is our Provost, so is responsible for all the academic programs here at the university. And DP Harris, you met first. Stand up, DP. DP is our Vice President for Information Technology and Information Services here and keeps all of us running. Okay, who have I missed? Ken, you better stand up as well. Ken Breyer deals with all our construction stuff, but he gets involved with helping when you guys send us needing design stuff in various places. Why Ken is the one we often turn to help be able to identify building issues and so on. Am I missing somebody else that I should be? I want to end by talking about this picture just briefly. Those of you who've been here now and walking back across here, you see a bunch of construction. We are getting ready to close Stewart Street right out here in front of this building, and we'll be building the Centennial Bridge that will go across Stewart Street and on up to the front of the Centennial Complex, which is the building we are in now. As you walk down that pathway, you will see many historical markers talking about the different events in Loma Linda's history from 1905 up to 1983. We stopped in 1983 because the ground started sloping down. We didn't want to tear it down before we built this bridge. But now we're getting ready to build the bridge, and we're putting historical markers on up to today. But we also need to we're putting the sidewalk in, so we need to put historical markers up until about 2060. But obviously that history hasn't been written yet. And so the question I want to leave with you tonight is, what will be in those historical markers? I wouldn't be surprised if there's a world war or two somewhere in those historical markers. What else will be there? Will the big earthquake hit California and be in one of those historical markers? That's a history waiting for each one of us to write. It's going to be a critical history. We are facing, I believe, some of the most challenging times this world has ever seen. The civil stress around the world seems to be gradually getting worse. And whether it's coming from political forces or religion forces or whatever it's coming from, we're in a tough time in this world. And I think it's going to be critical that we all are effective in what we do. We have people that die in these circumstances. As you know, we still bury people abroad near your institutions who've gone out to serve, and either children have died or parents have died. So there are still tough situations out there. There are still diseases in this world that claim too many lives. The group in this room tonight has the potential for significantly impacting